Hello everyone. In this presentation, we will be discussing anticoagulants. Note that the reference for this presentation in your textbook is chapter 21, pages 275 to 282. So remember from the previous lecture that the physiological response to vascular injury that attempts to stop bleeding or extravasation from an injured blood vessel involves three steps, which start with vasospasm, followed by the activation and aggregation of platelets, and lastly, by the formation of the thrombus. Remember that the formation of thrombus happens through the activation of the coagulation pathway. Remember also from the previous lecture that the activation of thrombin is very important in order to hydrolyze fibrinogen into fibrin, which is then deposited into the platelet plug to start building on the thrombus. It is very important to note here that thrombin, which is activated from prothrombin, is a result of the activation of a cascade of coagulation factors. We call it the coagulation pathway. So let's take a look at that in more details. So the coagulation pathway that generates thrombin consists of two connected pathways. We call those the extrinsic pathway and the intrinsic pathway. You will also notice that each pathway consists of different coagulation factors that are different from the other pathway. However, these two pathways are not completely separate. The relationship is more complex and they can be connected in many different ways. But just for simplicity, we'd like to describe them as two different pathways, especially that anticoagulation drugs will work, as at least that's what we think, that they will work at pathways separately. For example, heparin-based compounds usually interfere with the activity of the intrinsic pathway. Now, in each pathway, what happens is that these coagulation factors, which are in fact are serine proteases or zymogens, meaning that these factors are inactive in the normal states, but once they are activated, they exhibit an enzymatic activity or a serine protease activity, and thereby they can cleave or activate the next factor in the pathway. For example, the intrinsic pathway starts with factor 12. In the normal condition, factor 12 is not activated, but if it is activated, and we will see how in a minute, factor 12 activates its serine protease activity, which allows it to cleave and activate factor 11. And this continues throughout the cascade until both pathways eventually lead to the activation of thrombin. Note here that thrombin is also a inactivated coagulation factor because prothrombin is coagulation factor 2, while thrombin is the activated form of coagulation factor 2. So let's start talking about how these two pathways are activated. We'll start with the extrinsic pathway. The extrinsic pathway is initiated by the activation of clotting factor number 7. This is the first coagulation factor to be activated. And coagulation factor 7 is activated by a protein called tissue factor. Another name for tissue factor is thromboplastin. So thromboplastin or tissue factor is a membrane protein that is normally hidden from the blood by the endothelial cells that line the vasculature. So in a normal condition where there is no vascular injury and the endothelium is intact, tissue factor is hidden below the endothelial layer and is not exposed to the blood. Note here that all coagulation factors circulate freely in the plasma in the inactive form, as long as everything is normal. So now let's assume that the blood vessel was subjected to physical trauma. We had some sort of damage in the blood vessel. This means that um, coagulation factor in the blood will be exposed directly to tissue factor. The exposure of factor 7 to tissue factor will result in its activation. After factor 7 has been activated into its active form, it then activates factor 10 into its active form, which then leads into thrombin activation. So the extrinsic pathway is relatively shorter than the intrinsic pathway. On the other hand, the intrinsic pathway is triggered by the activation of factor 12. So factor 12 is the first coagulation factor in the pathway. And in order to activate factor 12 in cases of damage to the blood vessel wall, factor 12 has to be exposed or has to be in contact with exposed collagen that then becomes in direct contact with blood. Activation of factor 12 results in the activation of factor 11, then factor 9, and eventually factor 10. Remember again that thrombin plays the most important role in the coagulation pathway because it is the coagulation factor that is responsible for the generation of the fibrin clot. Meaning that if thrombin was not formed or if its function was blocked, then coagulation would be inhibited and you won't be able to form the fibrin clot. One of the factors that can inactivate thrombin is another protein called antithrombin 3. And antithrombin 3 has an antagonizing function to both thrombin or activated factor 2 and to activated factor 10. So it can inhibit the coagulation cascade at both these steps. Furthermore, remember that it is very important that when you want to form a clot, that this clot has to be limited to the site of injury, okay? You want it only to grow at the site of injury because otherwise, if the clot keeps forming indefinitely, then the clot will occlude the blood vessel and spread throughout the vessel to distant places. We don't want that to happen. And that is why we have antithrombin 3, which opposes the function of thrombin and clot formation and also inhibits activated factor 10. In addition to antithrombin 3, we have other proteins that also exert the same function, including protein C, protein S, and tissue factor pathway inhibitor. All these factors, in addition to antithrombin 3, can inhibit the coagulation factors and inhibit coagulation. So now if you start thinking about this, this probably provides a good target for the development of anticoagulant drugs. If you want to think about several certain mechanisms where you can interfere with the coagulation pathway, then you will probably want either to inhibit the synthesis of the coagulation um, factors in both the extrinsic and intrinsic pathway. You would probably also would utilize the function of antithrombin 3 to inhibit thrombin from forming the clot. These are some of the mechanisms that we will be discussing further as we start taking the drugs that are used as anticoagulants in the clinic. Let's start with parenteral anticoagulants, meaning anticoagulant drugs that are given through the intravenous or intramuscular routes. So the first and most important parenteral anticoagulant is the drug heparin. You will learn and listen, hear about heparin more and more as you progress in your medical education, and you will probably be using heparin during your medical practice. It's a very important drug. Heparin is an injectable, rapidly acting anticoagulant that is often used acutely to interfere with the formation of thrombi. Note here also that heparin is a naturally derived drug. It is basically a glycosaminoglycan that is found in association with histamine stored in mast cells. We unfortunately don't understand the exact physiological role of heparin, but we can extract heparin usually from porcine intestinal mucosa, basically from the intestines of pigs, and purify it and use it as a very powerful anticoagulant for the treatment of acute thrombotic diseases. So, for that purpose, for therapeutic purpose, heparin exists in two main forms. The first form is called unfractionated heparin, and this is basically a very large mixture of straight chain, negatively charged, highly acidic glycosaminoglycans. So heparin is not just one molecule, it is a mixture of different glycosaminoglycans, and those glycosaminoglycans have different molecular weights. Okay, they can either be big molecules or small molecules. And we noticed in that if we inject only the glycosaminoglycans that have the lowest molecular weights, we can still get the anticoagulant function of heparin. That's why we were able to purify only the low molecular weight forms of heparin to use as anticoagulants, and we call those low molecular weight forms of heparin. And these basically represent molecules that are one-third of the total size of unfractionated heparin. We have two drugs under this category that are very commonly used, and these are called enoxaparin and dalteparin. These two low molecular weight heparins are very effective anticoagulants. So let's discuss the mechanism of action of heparin. Remember that we said that antithrombin 3 is the protein that antagonizes the function of thrombin and coagulation factor 10. So what happens is that antithrombin binds to the coagulation factors, whether it was coagulation factor 10 or thrombin, and results in its activation, preventing the conversion of fibrinogen into fibrin. This, of course, interferes with clot formation. However, the ability of antithrombin to inactivate thrombin and factor 10 is very slow. So what heparin does is that it binds to heparin, it binds to antithrombin 3 and forms a complex, resulting in enhancing the activity of antithrombin, which results in catalyzing the inhibition of thrombin 1,000 times more than its normal activity. So heparin does not directly inhibit the function of thrombin or factor 10. On the other hand, heparin binds to antithrombin, resulting in a conformational change in antithrombin, causing it to fastly or more rapidly to inactivate thrombin and factor 11. Now, heparin binds to antithrombin through a unique pentasaccharide sequence located in the heparin molecules. By pentasaccharide, we mean that it's a sequence of sugars composed of five saccharides connected to each other. Remember that heparin is a glycosaminoglycan, and glycosaminoglycans are molecules that consist of proteins and sugars. So a sequence of five connected sugars in the heparin molecules are enough for it to bind to antithrombin, resulting in its activation or enhancement. This basically explains how low molecular weight heparins can still be active. Note in this figure, this is just an illustration of unfractionated heparin, large molecules with large molecular weight, and these are the low molecular weight heparins. But note that both molecules still have that unique pentasaccharide sequence that is necessary for it to bind to antithrombin to activate. Okay. Um, but note here that while unfractionated heparin is capable of binding antithrombin, that results in the inactivation of both factor 10 and thrombin. Both of these are inactivated by the enhanced function of antithrombin. Binding of low molecular weight heparins to antithrombin can only inactivate factor 10. It has very minimal or almost no activity on thrombin. That means that low molecular weight heparins selectively accelerate the interaction of antithrombin with factor 10 only, while unfractionated heparins accelerate the interaction of antithrombin with both thrombin and factor 10. So this is a very important difference between the mechanism of action of these two forms of heparin. This allows us for the use of heparin for the treatment of many thromboembolic conditions. The major use of heparin is for the treatment. Note here that it's for the treatment, not the prophylaxis. It's the treatment of acute venous thromboembolism in the form of deep venous thrombosis, which reflects abnormal thrombus formation in the deep veins of the lower limbs, or pulmonary embolism, which results from the dislodging of a piece of the thrombus formed in the large veins of the lower limbs that then travels and includes the pulmonary circulation. So both of these life-threatening conditions are treated acutely with heparin. We can also use heparin as a prophylactic agent against venous thrombosis, especially in patients who are at risk or those who are undergoing major surgeries, such as hip replacement. We also use heparin as the treatment of choice for thromboembolic diseases in cases of pregnancy. Can you think about why heparin is the preferred drug? Note here that while using unfractionated heparin for the treatment of these disorders, you will constantly need to monitor blood parameters such as bleeding time, prothrombin time, etc. But with low molecular weight heparin, you would actually be able to use it without this requirement to monitor um, uh, bleeding times, and that is why low molecular weight heparin is a safer drug to be used in the outpatient setting. So as we said, heparins are injectable drugs and they have to be administered either subcutaneously or intravenously because these drugs have poor absorption. The low molecular weight heparin are usually administered subcutaneously. However, enoxaparin can be given intravenously during the acute treatment of myocardial infarction. Heparin is often initiated as an intravenous bolus, meaning a large concentration of the drug in the first dose given. And this is often to achieve immediate anticoagulation, very fast action. But this is usually followed by lower doses or continuous infusion of heparin, where we can titrate it or reduce the concentration gradually to achieve the desired level of anticoagulation. While we are measuring, remember with unfractionated heparins, we said we need to measure bleeding variables, including the activated partial thromboplastic time, APTT, or the anti-factor 10 levels. Whereas the effect of heparin occurs within minutes of IV administration, unfractionated heparin is very fast in exerting its anticoagulant effect. The low molecular weight heparins usually require more time, around 4 hours, to achieve maximum anticoagulation after their subcutaneous administration. So in the plasma, unfractionated heparins are heavily protein bound. Remember that they are large molecules and they're heavily bound to albumin, and that explains why they have unpredicted pharmacokinetic profile, which means that with unfractionated heparins, as we said, you always have to monitor uh, bleeding variables to make sure that you're achieving anticoagulation effects, but to a safe extent, because excessive or overactivity of unfractionated heparins can be associated with bleeding. On the other hand, the pharmacokinetics of low molecular weight heparins are more predictable, and that is why they don't require very strict monitoring of coagulation values and bleeding times. However, in renally impaired patients, in pregnant ladies, or in obese individuals, monitoring of the levels of activated factor 10 are recommended when you are using low molecular weight heparin. So while heparins are largely confined to the circulation, they're restricted to the circulation, circulate in blood most of the time. They can be taken up by monocytes and macrophages located in the blood or in the peripheral tissues, where heparin undergoes depolymerization and desulfation into inactive products. This means that heparins do not undergo extensive hepatic metabolism. The majority of their metabolism and degradation happens in monocytes and macrophages, which means they can be used relatively safely in patients with liver disease. However, the inactive metabolites of heparin, as well as portions of the parental drug, are eliminated by renal clearance, meaning that heparin and its inactive metabolites are heavily excreted in the kidney. And that explains why you will need to use these drugs with caution in patients with kidney disease. And this also explains why you need to monitor coagulation factor levels and bleeding time in patients receiving low molecular weight heparins and also have kidney disease. Lastly, the half-life of heparins are different. As we said, unfractionated heparin usually achieves anticoagulation faster, and it has a half-life of 1.5 hours. On the other hand, low molecular weight heparins usually require 4 hours to achieve maximum anticoagulation, and they have a half-life ranging from 3 to 12 hours. Okay, let's start talking about the adverse effects of heparin. Because heparin's main function is anticoagulation, this means that the chief complication or the major adverse effects that results from heparin use is bleeding. So this is the most important thing that you should worry about while giving heparin to patients. And that's why when using unfractionated heparins, you always need to monitor coagulation factor levels and bleeding times. So what happens if you, for example, give heparin at larger doses, or if the patient starts developing severe bleeding due to heparin use? So there are two things that can be done in this situation. The first thing is that you have to discontinue heparin by gradually reducing the dose and completely stopping the treatment. And if the bleeding was severe enough, you will need to use heparin antidote. An heparin antidote is a drug called protamine sulfate. It is very important to remember this drug because it is very useful and important for the treatment of emergencies caused by bleeding resulting from heparin use. So protamine sulfate is a drug that is very similar in structure to heparin. And that is why when protamine sulfate is administered, it forms a stable one-to-one complexes with heparin. Like if this is the heparin molecule, it's usually a chain of glycosaminoglycans. Uh, Protamine sulfate, since it's structurally very similar to heparin, it forms a one-to-one complex, meaning each molecule of heparin will be neutralized by a molecule of protamine sulfate, and that inhibits further heparin function. However, remember always that protamine sulfate by itself, since it's very structurally similar to heparin, it is a weak anticoagulant. And that is why it has to be given very slowly at a rate of 1 milligram for every 100 units of heparin in order to avoid protamine sulfate itself to cause bleeding. So you just want to use it very slowly at very low doses, only to neutralize heparin and stop bleeding caused by heparin. This is very important. Remember that heparins, especially unfractionated heparins, are naturally derived. We develop them from collecting intestinal mucosa of pigs. This means that they can be associated with allergic reactions or hypersensitivity reactions. And this usually happens fastly after heparin is administered either intravenously or subcutaneously. And the hypersensitivity reaction in response to heparin usually involves chills and fever, urticaria, and sometimes it can be severe enough to cause anaphylactic shock. Another very important adverse effect of heparin is a condition called heparin-induced thrombocytopenia. So in certain patients who start heparin therapy, they will start developing an immune reaction that will reduce the number of platelets significantly in the blood. Okay, hence the name thrombocytopenia. Okay, thrombocytopenia means very low platelet count in the blood. And that is associated with a high risk of both venous and arterial embolism. And I understand that this is against logic, since the decreased number of platelets shouldn't be associated with thrombotic event. But this is a paradoxical phenomenon noticed with heparin therapy. So heparin-induced thrombocytopenia can increase the risk for arterial and venous emboli or embolism. This means that you can't just simply stop heparin because you are already using heparin as an anticoagulant to prevent further formation of thrombi. So if heparin-induced thrombocytopenia starts causing generalized thromboembolism, you need to solve the problem. So what we do is that we discontinue the use of heparin because it is the reason for this problem, but we have to replace heparin with another anticoagulant, with another preferably parenteral anticoagulant, such as the drug argatroban, which we will discuss in a few. Note here that if you were using unfractionated heparin and that resulted in causing heparin-induced thrombocytopenia, it is not advised to stop unfractionated heparin and replace it with low molecular weight heparin because low molecular weight heparin can also be associated with heparin-induced thrombocytopenia. And lastly, chronic use of heparin is associated with osteoporosis. Based on that adverse effects profile, heparin is contraindicated in patients with several conditions. First, patients who are allergic or hypersensitive to heparin should not use heparin, of course. Patients with bleeding disorders, like, for example, hemophilia, who are already at risk of abnormal bleeding, should not take heparin. Patients who have chronic alcoholism, or those who had a recent surgery, especially of the brain, eye, or the spinal cord, because these patients will still have active wounds, meaning that heparin will interfere with the coagulation process leading to wound healing, and they may start suffering from bleeding. Okay, let's now discuss other parenteral anticoagulants that are also available for use. Just keep in mind that heparin is the most commonly used anticoagulant, and these drugs are usually used as alternatives. So the first one is a drug called argatroban. Argatroban is a synthetic anticoagulant derived from the amino acid arginine. Remember that heparin is naturally derived. These drugs are synthetic. Uh, the mechanism of action of argatroban is that it acts as a direct thrombin inhibitor. Remember that this is different from how heparin exerts its anticoagulant effects, because heparin does not directly antagonize thrombin. Instead, heparin binds to antithrombin 3 and enhances its activity, and antithrombin 3 in turn inactivates factor 10 and thrombin. So argatroban does that directly by inhibiting thrombin. Argatroban can be used, as we mentioned previously, in cases where patients taking heparin develop heparin-induced thrombocytopenia. It can also be used instead of heparin in patients who you already know that they are at risk of developing heparin-induced thrombocytopenia. They have a previous history of a similar episode. So you don't want to risk and use heparin one more time. You can replace it with argatroban. Argatroban is very fast. It initiates anticoagulations immediately after its administration. It has a half-life of around 40 to 50 minutes, and it undergoes hepatic metabolism. Make sure that always to monitor hemoglobin, hematocrit levels, in addition to other bleeding times such as APTT. Again, the major adverse effects that is associated with argatroban is bleeding. Bivalirudin and disirudin are semi-synthetic compounds. They are analogs of the natural substance hirudin. Hirudin is a natural thrombin inhibitor that is found in the saliva of medicinal leech, العلق الطبي. So these drugs are just analogs to the natural substance found in leech. And their mechanism of action is that they can selectively and directly inhibit thrombin. Okay, so they are more similar to argatroban. They're different from how heparins work, and they can inactivate circulating thrombin and thrombin that is attached to the forming clot. And bivalirudin can be used as an alternative to heparin in patients undergoing percutaneous coronary intervention, القسطرة, who are at risk of developing heparin-induced thrombocytopenia, as well as it can be used in cases of unstable angina that is also undergoing PCI or angioplasty. Disirudin is used to prevent deep venous thrombosis (DVT) in patients who are undergoing major surgeries, especially hip replacement surgery. Remember that these orthopedic surgeries involving large bones or large joints, such as the hip joint or the knee joints, are usually associated with a prolonged period of immobilization. The patient will have to remain in bed for months, and that is associated with usually venous stasis. And venous stasis is a major risk factor for the development of deep venous thrombosis. So these patients need to take anticoagulants as a prophylactic therapy. Lastly, fondaparinux is a synthetic anticoagulant. It is basically a pentasaccharide. Remember that when we discussed the mechanism of action of both unfractionated heparins and low molecular weight heparins, we indicated that a pentasaccharide sequence in the heparin molecule is the active sequence that is required for its binding and activation of antithrombin 3. So fondaparinux is basically just a synthetic pentasaccharide. Just we took that pentasaccharide from the heparin molecule and we now synthesize it as a drug. This is all you need to activate antithrombin 3. That's why fondaparinux exerts its anticoagulant effects by binding to antithrombin 3, potentiating its effects and ability to inactivate factor 11 only. And this is similar to how low molecular weight heparins work. Fondaparinux is definitely used for the treatment of deep venous thrombosis and pulmonary embolism, and also can be given for the prophylaxis against these conditions in patients undergoing major abdominal or orthopedic surgeries. The pharmacokinetics of fondaparinux are predictable. It's very similar to low molecular weight heparin, and that's why you don't need strict monitoring of blood components while giving fondaparinux therapy. But again, fondaparinux can still be associated with bleeding as an adverse effect, similar to all the other parenteral anticoagulants. So let's now review some of the concepts that we've discussed so far about parenteral anticoagulants. Let's discuss this case first. You are the leading physician scientist in a pharmaceutical company that is involved in the development of anticoagulant drugs. You were asked by the head of the department to write an abstract summarizing the established and future mechanisms to design drugs that can effectively reduce thrombosis by interfering with the coagulation pathway. Which of the followings will not be a mechanism that you will include in your summary? So if you look at all of these mechanisms uh, and you understand how coagulation happens and how coagulation is inhibited, you will be able to pick the correct answer. For example, uh, protein C is remember that is one of the factors that prevent thrombin activation and yet prevent thrombus formation. Okay, so activation of protein C will definitely have an anticoagulant effect. Inhibition of thrombin will definitely have an anticoagulant effect, and that is the mechanism of action of many parenteral anticoagulants. So you would want to include that. Activation of antithrombin 3 will result in the inactivation of factor 10 and thrombin, and that will definitely have an anticoagulant effect, and that's how heparin works. Activation of coagulation factor 10 will result in more coagulation, right? Because remember that the activated factor 10, which happens as a last step for both the extrinsic and the intrinsic pathway, is responsible for the activation of thrombin, right? So activation of factor 10 will result in thrombus formation. So that mechanism will not have an anticoagulant effect. That is why it is the right choice. It should not be included as a mechanism of anticoagulation. Here's another simple question. Which must heparin bind to in order to be able to exert its anticoagulant effect? Remember that all of these are drug targets for many of the drugs that we discussed in this module. For example, glycoprotein 2B3A receptor is the target for many antiplatelet drugs, such as the drug abciximab. Um, Van Willebrand factor is also another important part of platelet plug formation. However, it's not the target of heparin. So you are left with two options, either thrombin or antithrombin 3. Remember that heparin does not directly inhibit thrombin. Heparin, on the other hand, binds to antithrombin 3 and enhances its activity to inhibit thrombin. So it's an indirect way of thrombin inhibition. So the correct answer is C. Next, we'll now move from discussing parenteral anticoagulants such as heparin, argatroban, and fondaparinux, and we'll now start discussing oral anticoagulant agents, or what we refer to as vitamin K antagonists. So let's start by discussing warfarin. Warfarin is the most important oral anticoagulant drug. It is widely used for the treatment of thromboembolic disorders. You will need to know all the details in regards to warfarin in terms of its mechanism of action, drug-drug interactions, pharmacokinetics, adverse effects, and how we can treat warfarin toxicity. Warfarin is a coumarin analog. It has a chemical structure that's very similar to coumarin. Coumarin is a naturally occurring substance that is present in many plant sources, such as spices, for example, like cinnamon. Um, Warfarin is the only coumarin-derived anticoagulant that is available for use in the United States and in Jordan. Note here that warfarin requires strict monitoring of bleeding time, and all patients who are on warfarin therapy will require periodic testing for INR. As you might know from your physiology, INR. So how does warfarin work? In order to understand the mechanism of action of warfarin, we need to revisit how some of the coagulation factors are synthesized. So the major site for the synthesis of most coagulation factors, including factor 2 or prothrombin, factor 7, 9, and 10, is in the liver. Most of these coagulation factors are synthesized in the liver. After these factors are synthesized, they undergo vitamin K dependent post-translational modification. So in order for these coagulation factors to be effective, they need to undergo a carboxylation reaction. This carboxylation reaction involves the addition of a carboxyl group from a glutamic acid residue. And we refer to the addition of this carboxyl group as the gamma carboxyl glutamyl residue. Okay, this residue, the addition of this carboxyl group to the newly synthesized coagulation factor, is very important for the activity of these factors because this side chain allows these factors to bind to platelets. Okay, now in order to successfully achieve this reaction, vitamin K is required. Vitamin K acts as a cofactor in this reaction, and it allows for the addition of this carboxyl group to the newly synthesized coagulation factors. In this reaction, vitamin K is converted from the reduced form into the oxidized form, or vitamin K epoxide. So you will always require the availability of the reduced form of vitamin K so that this reaction can go successfully. After this reaction is completed, vitamin K in the oxidized form is then recycled back into the reduced form in order to carry on with further reactions. The enzyme that is responsible for reducing the oxidized form of vitamin K back into the reduced form that is required for the carboxylation coagulation factor is called vitamin K epoxide reductase. As the name indicates, this enzyme reduces vitamin K and converts it from the epoxide or oxidized form into the reduced form. Warfarin inhibits the action of vitamin K epoxide reductase, reducing the availability of the reduced form of vitamin K. That means this will interfere directly with the carboxylation of coagulation factors. Now, note here that warfarin does not basically interfere with the synthesis of these factors. They will continue to be synthesized. However, they will be present at uh, lesser activity because they will miss this carboxylation reaction. So coagulation factors in the presence of warfarin function at 10 to 40% of their normal activity. So they will have reduced activity. And that's how warfarin interferes with the ability of these coagulation factors to result in thrombus formation. That's why warfarin is a very strong anticoagulant. So because of its potent anticoagulant effect, warfarin is used for the prevention and treatment of many thromboembolic diseases. For example, warfarin is used for the prevention of deep venous thrombosis and pulmonary embolism. It can also be used for the prevention of cerebrovascular accidents. More importantly, warfarin is used to prevent stroke in patients who have atrial fibrillation of prosthetic heart valves. Remember that patients who have atrial fibrillation can have blood pooling in their atria, depending on which atrium is affected. And if blood pools in an atrium, blood stasis would result in thrombus formation. If that thrombus forms in the left atrium, for example, it can break, dislodge, and then travel through the aorta to the cerebral circulation and result in clogging a major cerebral blood vessel, resulting in stroke. So these patients should be given anticoagulants such as warfarin to reduce the risk of cerebral thromboembolism. Remember that proteins such as protein C and protein S have an anticoagulant effect. They oppose the function of thrombin, and patients who have inherited protein C and S deficiencies are liable for an increased risk of thromboembolic disorders, and that's why they should be treated with warfarin. Similarly, patients with antiphospholipid syndrome have a higher risk of thromboembolic events. Antiphospholipid syndrome is an autoimmune disorder that is more common in females. And lastly, warfarin uh, can be used to prevent thromboembolism that follows prolonged periods of staying in bed following major surgeries such as hip replacement surgery. The pharmacokinetics of warfarin are very important. Warfarin is given orally for sure, and it has a 100% bioavailability, meaning that warfarin is highly absorbed from the gastrointestinal tract. Now, warfarin does not readily cross to most membranes, like, for example, it poorly or doesn't cross the blood-brain barrier. However, warfarin crosses the placenta and it can result in severe teratogenic effects in the fetus in the pregnant woman. That's why warfarin is listed as a category X drug, meaning that is contraindicated for use during pregnancy. It can be considered drug D in pregnant ladies who also have a prosthetic heart valve installed. This should remind you about the drug of choice to produce anticoagulation in pregnancy. Can you remember it? Okay, warfarin in plasma is highly protein bound. Almost 95 to 99% of warfarin is bound to plasma proteins, mainly albumin. This makes warfarin susceptible for drug-drug interaction if it was given with another drug that is also bound to plasma proteins, such as sulfonamides, the antibiotic sulfonamides. So, let's see what happens if warfarin was given at the same time with a sulfa drug. So, let's consider this a drawing of plasma proteins such as albumin in the plasma. For most plasma proteins, there are designated sites to where drugs can bind. And as we said, 99% of warfarin is bound to albumin or other proteins in the plasma. Okay, so it's heavily bound. And only 1% exists as in the free form in the plasma. Now remember that only the free form of the drug can exert its effect and can be metabolized by the liver and excreted by the kidney. So this is the active form of the drug that we care most about. So as we said, usually in normal conditions, the percentage of free warfarin is 1%. So what happens if the patient takes a sulfa drug at the same time? Remember that sulfa drugs have a greater affinity to bind to albumin than warfarin. So if they start circulating in the plasma, these drugs will replace warfarin from being bound to albumin. Okay, so will take over. This will result in the displacement of warfarin into the plasma so that it will exist in the free form more. So the percentage will increase. This means that there will be more warfarin available to act as an anticoagulant. This will definitely potentiate the anticoagulant effect of warfarin. And because warfarin has a very narrow therapeutic window, as we said, these slight changes in its non-bound free concentrations in plasma can be associated with life-threatening bleeding. So in case warfarin was to be given with a sulfa drug, the dose of warfarin has to be adjusted. Warfarin has a fairly long half-life of around 40 hours. Remember, and this is very important, that the peak effect or the peak maximum anticoagulant effect of warfarin is delayed. It's not achieved until around 72 to 60 to 96 hours after administration. And this time reflects the time that is required for the production of coagulation factors from the liver. Remember that warfarin interferes with their synthesis. So at any given point of time, when you give warfarin to a patient, they will have some coagulation factors circulating in the blood, meaning that for around 2 to 3 days, they will be able to coagulate their bloods normally until warfarin has completely interfered with coagulation factor synthesis. And this, of course, this half-life varies according to the coagulation factor. You can see these values here. For example, it takes warfarin 72 hours to completely interfere with the synthesis of factor 10. So, a very important concept also with warfarin is that in cases of warfarin toxicity, remember that warfarin has a very narrow therapeutic window. And if the patient is taking warfarin with, for example, a sulfa drug or another drug that interferes with warfarin metabolism, or if you give an overdose of warfarin, patients will suffer from bleeding. And fortunately, we have an antidote to warfarin, and that antidote is simply just replacing vitamin K. So, in patients who are suffering from warfarin associated bleeding, vitamin K is the preferred antidote. It will replenish vitamin K levels in the liver, allowing for the proper synthesis of coagulation factors. Note here that vitamin K would require around 24 hours to overcome the anticoagulant effects of warfarin because that is usually what it takes to start synthesizing new coagulation factors. Warfarin is inactivated in the liver by being metabolized by the CYP450 system, especially the enzyme CYP2C9. Uh, this means that warfarin is subjected to many drug interactions as well as food drug interactions. For example, grapefruit juice or grapefruit cranberry juice, other green leaf vegetables such as like kale, for example. These food products can inhibit CYP2C9. This means that they can interfere with the metabolism or inactivation of warfarin in the liver, indicating that warfarin will exist in higher plasma concentration at a given dose. This means that consuming these food products along with warfarin therapy might increase the anticoagulant effect of warfarin. And patients taking warfarin should be educated about all the food products that they cannot have while taking the drug. Similarly, there are many drugs that interfere with warfarin metabolism. For example, uh, CYP2C9 inhibitors such as sulfa drugs, metronidazole, fluconazole, amiodarone, etc. All these compounds inhibit CYP2C9 enzyme that metabolizes warfarin, and this results in a higher plasma concentration of warfarin and potentiation of its anticoagulant effect. This means more risk for bleeding, of course. Um, these are examples on a pharmacokinetic drug-drug interaction. But we can also have a pharmacodynamic drug-drug interaction, meaning that if warfarin was given with another drug that has a similar effect or similar mechanism of action, you will also potentiate the anticoagulant effects of warfarin. For example, if you take warfarin with aspirin, and aspirin is an antiplatelet drug, right? It will also prevent thrombosis. So warfarin and aspirin combined together means that you will have a higher anticoagulant effect and more risk for bleeding. Similarly, there are a group of drugs that actually stimulate the enzyme CYP2C9. So they enhance the metabolism of warfarin and they can decrease its anticoagulant effect because enhancing the metabolism of warfarin by CYP450 system means that you will convert warfarin into its inactive metabolites faster. And an example on these drugs is phenobarbital um, or other barbiturates. So the major adverse effect of warfarin is definitely bleeding, similar to all the other anticoagulants or antiplatelets that we have discussed in this module. And patients who have or start suffering from warfarin-associated bleeding must be treated immediately by stopping warfarin and then giving vitamin K, whether in an oral or intravenous form, as an antidote to warfarin. Now, because vitamin K requires 24 hours to start working, if the bleeding was very severe, you will need to replace coagulation factors in the patient, and that is achieved either by giving whole blood or blood transfusion or the administration of fresh frozen plasma, which contains a variety of coagulation factors that are required for proper coagulation. And you can replace coagulation factors individually, like if your laboratory tests came back with very low levels of coagulation factor 10, for example, you can just replace coagulation factor 10. And these measures are usually faster than the treatment with vitamin K, which could require a few hours to start work. In addition to bleeding, warfarin can be associated with other adverse effects, such as skin necrosis caused by the formation of microthrombi in the peripheral tissues. And this is a picture of skin necrosis localized to the lower limbs. Yes, of course, this can be life-threatening, resulting in ischemia and permanent damage to skin in the lower extremities. Also, patients taking warfarin can develop what we call purple toe syndrome. And purple toe syndrome is a rare syndrome characterized by painful blue-tinged discoloration of the fingers and toes. And this is usually caused by cholesterol emboli from plaques that can mobilize and occlude small vessels in supplying those areas. Don't forget that warfarin is a highly teratogenic drug and should not be used during pregnancy. It is always useful to compare the characteristics of the most commonly used parenteral anticoagulant heparin with the most commonly used oral anticoagulant warfarin. So remember that there is a difference in the mechanism of action, and that heparin inactivates both thrombin and factor 10 indirectly via enhancing the function of antithrombin 3, while warfarin interferes with the synthesis or the post-translational modification of several clotting factors. Heparin is given parenterally, whether intravenously or subcutaneously, while warfarin is given orally. Note that warfarin is highly teratogenic, and that is why it's contraindicated in pregnancy, while heparin can be used for the treatment of thromboembolic disorders during pregnancy because it does not cross the placenta or is not secreted into the breast milk. Heparin is faster. It's especially when we talk about unfractionated heparin. It produces anticoagulation very fastly in comparison with warfarin, which usually requires 24 to 72 hours to achieve maximal anticoagulant effect. Warfarin, since it's metabolized in the liver, it has many drug-drug interactions. Heparin is not that much metabolized in the liver. Instead, it's metabolized in the monocyte macrophage systems, and it has fewer drug-drug interactions. But on the other hand, heparin is eliminated renally, which means its use is limited in patients with renal insufficiency, while warfarin tends to be safer in those patients. However, warfarin should be used with caution in patients with liver disease because it's heavily metabolized in the liver. With heparin, you would require constant monitoring of PTT, especially when you are using unfractionated heparin, while with warfarin, the blood variable that is monitored is INR. The antidote for heparin is protamine sulfate. while for warfarin, it's vitamin K. So let's take a quick question on the pharmacokinetics of warfarin. In an 80-year-old male who's taking warfarin indefinitely for the prevention of deep venous thrombosis, the patient had a stable INR, which means that his treatment with warfarin was okay. And we said that the therapeutic goal when warfarin is given is an INR of 2 to 3. But recently, this patient was diagnosed with a urinary tract infection and was prescribed sulfamethoxazole trimethoprim, which is a sulfa drug. So, which effect will happen due to this combinational therapy? So, remember that sulfa drugs are heavily protein bound. They have a higher affinity for binding to albumin than warfarin. And if it was given with warfarin at the same time, it will displace warfarin from plasma proteins, meaning it will increase the concentration of free warfarin in plasma, resulting in a potentiation in its anticoagulant effect. And that's why B is the correct answer for this question. This means that this patient will be more susceptible to bleeding from warfarin. In addition to warfarin, there are a few other oral anticoagulants that can also be used for the treatment of thromboembolic disorders, and we will take just a few examples on those. So these other oral anticoagulant agents are usually classified into two categories based on their mechanism of action. These drugs can either be direct thrombin inhibitors or direct factor 10 inhibitors. An example on direct antithrombin inhibitors is the drug dabigatran. Dabigatran directly inhibits thrombin, whether it was bound to the evolving clot or if it was circulating in plasma. And that results in the prevention of thrombin from forming a fibrin clot. And that's why dabigatran has a very potent anticoagulant activity, which allows for its use for the prevention of thromboembolism or cerebrovascular accidents that can result in patients with atrial fibrillation. But the condition here is that those patients with atrial fibrillation should not have a valvular disorder. Okay, they shouldn't have a dysfunctional valve or a mechanical valve. Dabigatran can also be used for the treatment of deep venous thrombosis and pulmonary embolism only if the patient has already received a parenteral anticoagulant such as heparin, uh, which means that you can't use dabigatran alone for the acute treatment of deep venous thrombosis. However, dabigatran is useful for the prophylaxis against deep venous thrombosis and pulmonary embolism in patients who are at risk. Dabigatran is, of course, an oral anticoagulant and it is eliminated by the kidneys. Its major side effect is bleeding, similar to all the other anticoagulant medications. But remember that it is contraindicated to be used in patients who have prosthetic or mechanical heart valves, even if those are at risk for thromboembolism. There are other options to treat those patients, such as warfarin. Also remember that dabigatran should be used with caution in patients with renal disease because it's excreted renally. Fortunately, we have an antidote for the treatment of dabigatran toxicity, and that is the drug idarucizumab. The other category of oral anticoagulants are drugs that can directly inhibit activated factor 10. These drugs include abixaban, betrixaban, edoxaban, and so forth. These drugs directly inhibit factor 10 or the activated factor 10, resulting in inactivation of thrombin or from thrombin and failure of the formation of a clot. Remember that heparin does the same thing, right? Heparin also interferes with the activation of factor 10, whether unfractionated or low molecular weight heparin. They both do that, but they don't do it directly. They do it by enhancing the function of antithrombin 3. These drugs directly inhibit activated factor 10. These drugs can all be used for the prevention of stroke and the treatment of deep venous thrombosis and pulmonary embolism, with the exception of betrixaban. Betrixaban can only be used for the prevention of DVT and pulmonary embolism in patients who are at risk, usually in the hospital, but it can't be used for the acute treatment. This definitely can cause bleeding. However, we don't have an antidote for this group of drugs. So based on the mechanism of action, can you think what would be the best approach for the treatment of bleeding caused by these drugs in patients who receive, like, for example, an overdose? Let's review some of these concepts. A 56-year-old male patient presents to the emergency room with complaints of swelling, redness, and pain in his right leg. The patient was diagnosed with DVT. These are usually the typical signs and symptoms of deep venous thrombosis. And then the emergency doctor wants to start an oral agent. Which of the following oral anticoagulants is the most appropriate for the treatment of DVT in this patient? Now, remember that clopidogrel, which is an antiplatelet, is not enough to be used for the treatment of deep venous thrombosis. That is basically should be excluded from your answer. Enoxaparin is very effective for the treatment of deep venous thrombosis, but enoxaparin is a low molecular weight heparin and is not an oral anticoagulant. Alteplase is a fibrinolytic agent, which we haven't discussed so far, so that is also eliminated. So this leaves us between rivaroxaban and betrixaban, and we mentioned that betrixaban is approved for the prophylaxis against DVT, but not for the acute treatment of deep venous thrombosis. This means that the correct answer for this question is A. Here's another practice question. A 70-year-old female was diagnosed with a non-valvular atrial fibrillation, meaning that she has an atrial fibrillation that is not associated with a valvular disease. Her past medical history is significant for kidney disease, and her renal function is moderately diminished. So she has an element of, or a degree of, renal failure. All of the following anticoagulants would be expected to require a reduced dosage in this patient, except. So this means that the drugs that would need reducing the dose are the drugs that are eliminated by the kidney. So which ones of these choices is a drug that is an oral anticoagulant useful for the treatment of this patient, but is not eliminated in the kidney and does not require dose adjustment in patients with kidney disease? The answer to this question is warfarin, because warfarin is majorly eliminated by hepatic metabolism. Thank you for listening to this presentation. Please, if you have any questions on this material, don't hesitate to contact me through Microsoft Teams or via email. Thank you.